I would love to share that data with other investigators here to collaborate with you all and help more folks become independently funded. So, for example, right now, Goshi Lee and I are putting in an R01 with him as the PI using data that I collected, and I think we have a good shot at it. So I think there's almost an unlimited possibility of collaborating with other investigators here at the BRIC and looking at ways of essentially clinical translation of your ideas, and in whatever way that I can assist with that, I would just love to do that with you guys. So I'm going to just kind of give you the story about how the heck I got here anyway. And I'm going to talk about epilepsy first and foremost, because most of the data I have centers around epilepsy. However, I have some data around movement disorders, and also now we're foraying into coma, covert consciousness, and this type of setting, all around resting state functional MRI in patients. So this is a clinical service here, as Ian said, at UNC, and it's applied for mostly folks undergoing epilepsy surgery evaluation, but also those with acute brain injury and coma, and we're talking about both adults and children. And so I'll just get started with that. So these are my disclosures. So when I was a neurology resident, I became dissatisfied with just using a hammer to decide where's the localization of the lesion as a neurologist. And I felt like a lot of the diagnoses we made did not have enough objective criteria around them. They were largely behavioral measures. And then we decided a patient had a particular diagnosis, and then we put them on drugs a lot of the time, and then we hope that they get better. But might there be better objective markers? And I think you guys know all about this, that of course there's better objective markers, and why don't we implement them clinically? So without further ado, I convinced my chairperson to allow me to go get trained at the Montreal Neurologic Institute during my residency, shoved all my call to one side of the residency, and then the rest of it went off to the Montreal and got trained in how to analyze resting state. And this was back in 2010. And so after I came back, I was doing some research related to autism and resting state and using the clinical scanner for that at Texas Children's Hospital. And in the process, I was also going to all my other training seminars, which included the Epilepsy Surgery Conference. And I remember in one particular case, the neurosurgeons were kind of scratching their heads and saying, well, the more brain we remove, the better off the child will be, because we know we remove the seizure onset zone. But this particular child didn't have normal behavior, so we couldn't really tell if they were using the tissue around the lesion that we were going to remove. And so we wouldn't know if we would be increasing the disability of the patient by doing that. And so I shot up my hand and said, well, at least I could show you where the resting state networks are around that lesion. And that spawned, from that point forward, every single patient getting epilepsy surgery evaluation at the largest pediatric hospital in the world at that point in time, and I think still is, getting a resting state for clinical reasons and me interpreting it. And of course, there was no automation at that time, and it took me 8 hours a patient, and I was just overwhelmed. Fortunately, I had a lot of great friends in the automation business, and we got to town on that in my garage. And so now I'm able to analyze patients clinically without too much problem. And so what you're looking at here are the resting state language networks. Each color is a different network, and these are detectable in a regular MRI scanner. And so this is the left side of the brain, and it shows spatial dominance of these language located networks compared to the right side. And so we can even help with understanding language dominance in children, which we published. And so as we were acquiring all this data, by the way, of course, resting state predicts the task-based function of folks out there, and that's work being done by other groups. And you guys know what task-based functional MRI is. I almost don't even want to tell you, but here's a patient opening and closing their eyes, that localizes to the visual cortex, and compare that to resting state that has this smooth, slow oscillation that is the basal activity of the brain and is always there unless we put the patient under general anesthesia or they're brain dead, and can compare that to the activation that we're looking at from task fold. So this is just the basal activity of the brain. And so, for example, here's bold activity over 560 seconds of one particular example network, the power spectrum from that bold signal of a normal network, and compare that to what bold signal looks like in a child who progressed to brain death hours after. We just see the cardiovascular pulsation down here. By the way, can you guys see my pointer? Probably not so well. Let me change it to...
Yes, I can see it. Yeah, no problem.
Oh, you see it. Okay, all right, great. I'll just keep going then. Okay, so after collecting data on many of these patients and looking at where their normal networks are, we started to notice these children that had drug-resistant epilepsy, that they also had signal sources from independent component analysis that didn't really fit with the normal networks, but also didn't fit with noise. And here's an example of that, where we had this relative amount of deactivation in the blue, activation, and kind of these alternating bands. And this patient had an EEG that showed abnormal seizure activity largely over the left side of the brain and a little bit on the right. And so you can see why the surface EEG might show that if this was a seizure onset zone. And we didn't really know what it was when we first encountered it. So we did a angiogram in this patient using a CT machine to make sure it wasn't a vascular malformation or something like that. And there was nothing there, which was good because we're going to put a depth electrode in this location. And you can see the bold signal from this signal source is a lot faster and erratic, has higher power spectrum than those normal resting state networks that I just showed you. And it's largely over gray matter. And so we got the idea that this might have something to do with seizures. So we put a depth electrode in this area, which this patient was getting depth electrodes anyway. We just made sure we put one here. And from this location, there was nonstop seizure activity that then transpired over to these locations that you see here. And so this gave us the good clue that, in fact, this really could have something to do with seizure onset zone, which if we adequately destroy the area causing the seizures, then we can render the patient seizure free, which is the only known cure of epilepsy for humans. So I'm not going to go into what is bold to you guys. You guys know what that is. So we remove this area surgically, and this patient remains seizure free. Here's the post-operative imaging here. So this, I don't intend for you to be able to read this, but just so you know that we have published since this time criteria for helping us classify between normal networks and noise sources, and then these so-called seizure onset zones. And what are the criteria we're using to sort out those signals that come from the independent component analysis? And we've applied these criteria in over 2,000 or so individual scans to help us understand where the seizure onset zone. And of course, this gets combined with all the other modalities the patient is receiving to help us understand where seizures are. And the epilepsy surgery team takes a look at all that data. And what we're trying to do is to get over different modalities of brain physiology to overlap in the same area to give us greater confidence in destroying irreversibly a part of the brain. So the more overlapping we can get from different modalities, including resting state, the more confidence we feel. The nice thing from the resting state is that we're not as spatially limited as in many of the other non-invasive means of localizing seizure. And just to give you an idea of what does noise look like, many of you guys know this as well or better than I do. Here's like from motion artifact, it's outside of the brain. Here's from venous sinus, it's co-localized with the venous sinuses. Here's CSF pulsation, you see this regular pulsing and co-localized with CSF location, so on and so forth. You can compare that to these nice normal looking networks such as this visual network, and then compare it to seizure onset zone signal sources, where you see that in this case, these overlapping signal sources, each of a different color, and then their bold, erratic bold character compared to normal resting state bold, nice, smooth, and slower in general. And you can see their power spectrum in general is higher. So this is a bird's eye view of what a clinical report would look like. Each page has each of the separate networks, resting state networks, normal and abnormal from the patient. And then I deliver a clinical interpretation of that, what that means for that particular patient. And so we can integrate these results to the interoperative surgical software, and that helps the surgeon more accurately destroy the area in question. And what we showed is that when we compared the resting state seizure onset zone with those identified from intracranial G, we had 90% agreement. And when we compared it to seizure outcomes after destruction of that area of the brain, that we had good sensitivity and specificity. And this was in our early phase back in 2013. So as another means of validation of this, we repeated the scans after surgery, regardless of the outcome, at 6 to 12 months. And what you see here is in those patients who became seizure-free, we saw normalization of the bold signal in the region where the surgery, in and around where the surgery had occurred, compared to these prior pre-op images that you see here in the darker blue background. Same here in this patient, where the overlapping region here between the red and the blue is a seizure onset zone that was removed surgically. And we had normalization of resting state signal from that region. And we published this. And as we got better at it clinically, with more experience, our sensitivity and specificity increased. Okay, so let's go through a case. We have time, right, Ian? How much time do we have? Like 30 minutes?
No, you got time. We'll have time until 1.
Okay, good. I'll keep going. By the way, if there's questions, just interrupt me. I would rather this be a discussion than, you know, a monologue. Okay, so here, let's all sit in the epilepsy surgery conference. We've got a 16-year-old right-handed male who had a history of meningitis as a baby. He's independent in daily skills. He's a B student in high school, but he has seizures every day. And so we conducted this series of modalities, trying to localize where the seizure is occurring. And by our video EEG, we could see seizures happening with right-sided hemispheric evolution, not super localizing there except by hemispheric. And then, so we had generalized slow waves with bilateral posterior temporal slowing with sharps. The MRI, which I'll show you anatomically, had anterior right, all right, anterior temporal and posterior occipital encephalomalacia and a small right fornix. The PET scan had interior right hypometabolism, and the resting state localized to the opposite side of the brain with a temporal based seizure onset zone, which I'll show you. And then the semiologies, which how they behaved during the seizure. The patient had confusion, lip smacking, and automatisms. So here is the anatomical MRI with right-sided anterior pole encephalomalacia, and also some in the posterior occipital region that you see here. This was the resting state seizure onset zone with greater mesial left-sided spatial extent than right, with increase in that power spectrum and more erratic in the bold signal, like I showed you previously. And so how did this affect the seizure epilepsy surgery planning? So by the other modalities, what you see here is the right-sided implantation of depth electrodes into the brain, here on the sagittal and axial views. And then because of the resting state pointing to the left mesial zone, we went ahead and implanted 2 more depth electrodes on the left into the mesial temporal areas that you see here. And so this run 1 is the first onset of epileptiform activity here in the left mesial zone, and it begins and then it starts to modulate, and then by run 2 it has started to fan out largely over the right side of the brain than the left side. And so essentially epileptic signal can unpredictably essentially take a turn to homologous regions and fan out over an opposite side of the brain, which would be why the seizure onset zone would be falsely localized to other parts of the brain by modalities that are less sensitive to deeper regions of the brain or interictal activity. So we also studied how did this perform in lesion negative epilepsy, and essentially we had the same level of agreement with the intracranial EEG and surgical outcomes. So it performed equally as well in the MRI negative or cryptogenic epilepsy. And then as a way of understanding how this is influencing and impacting surgery, we studied ourselves. So what we did was we presented all the other information besides resting state. We came up with a plan. Then we presented the resting state. Then we recorded how did that change our plan. And so what we found in this prospective study is that 26% more surgeries actually happened because of the resting state information. So that is a huge increase in surgical candidacy from one modality alone. And there was a 92% alteration overall, ultimately, in where that we thought the seizure onset zone was located. And there was a 58% change in the surgical approach. So, for example, in some instances, we might have done a craniectomy, which is a more invasive and difficult to heal from procedure than a minimally invasive approach, such as using a burr hole with a laser, which is essentially a day surgery. And since that time, there's been a meta-analysis out using these techniques to localize seizure with pretty good concordance across investigators. Further, other meta-analyses that are relevant is this one done that differentiated different types of epilepsy versus healthy control. So essentially, could we use resting state to even know if you have epilepsy at all, period? And if you do, then what kind of epilepsy do you have? And so they were differentiating based on location, if a patient had generalized versus temporal lobe versus other focal, and localizing to these different areas of the brain. And in another meta-analysis, essentially separating out, seeing if there was a difference between healthy controls and those with psychogenic non-epileptic seizures, meaning not epilepsy, essentially people who have behaviors that look like seizures, but in fact are not. And essentially, there was no difference between healthy control and normals in resting state who had these episodes. So another evidence that we could actually even use resting state to know if someone had epilepsy. So in conclusion, what we're seeing is that we have less spatial limitations than some other modalities for localizing seizure onset zone. There's no requirement for seizure during the scan, as with many other modalities where we need to, it's better if we capture ictal activity. Essentially, we're relying on abnormal oxygen utilization of these epileptogenic regions. This is safe for folks. If they're safe for an MRI, they're safe for a resting state. There's no requirement for patient cooperation, and this can be done under conscious sedation. Most pediatric patients, we are delivering low-dose conscious sedation so that they don't move, and we get excellent surgical grade resting state functional MRI. And this is just kind of a bird's eye view of a summary of the automation that's going on out there using artificial intelligence-based methods in the group that I've been collaborating with. And so we're not really at a point where we're ready for prime time using this technology, but it's approaching there. And if I had to guess, maybe 10 years out before clinical implementation for localizing pathological networks. Now, we're pretty good at picking out noise from normal, but once we put pathology into the mix, less is well understood using these techniques as far as seizure onset zone localization goes. And I guess I still have time. I'm going to talk to you about a particular type of epilepsy that's, I think, wonderful for showing us what's wrong in all types of epilepsy. And this is a rare disorder called hypothalamic hamartoma. So essentially, there's this collection of gray matter near the hypothalamus, and it generates seizures in some individuals. And they have these so-called gelastic seizures, which is laughing seizures, or dacrystic seizures or crying seizures, which is different than a lot of types of seizures out there. Although this isn't the only location that can produce those kinds of seizures, it's just the classic one for it. And so essentially what we did in collecting resting state in these individuals, we compared them in a group-wise approach against normals. And all these areas that you see on the left were the areas that were different from normal in those with hypothalamic hamartoma. And so then we asked ourselves, well, what's that got to do with the seizure generator. And so I did a partial correlation analysis between the hypothalamic hamartoma and those areas. And essentially what we saw is that these areas, the correlation between each individual area that was different from normal and the hypothalamic hamartoma itself stack ranked in p-value from top to bottom of the pathway of the seizures out of the hypothalamus along Papit's circuit, which was so interesting. And this was verified from prior sources using depth electrode data in live humans with drug-resistant epilepsy, that when the seizures leave the hamartoma, the first place they go to is the anterior thalamus, anterior cingulate, and so on and so forth around the Papit circuit. And you can watch this happening on these depth electrodes, and those stack ranked against the p-values of resting state. So that helped us understand that resting state might be helpful for determining where in the hamartoma are the seizures coming from, because it could actually help us track the seizures leaving the hamartoma. So we use this information in a data-driven manner to essentially place a voxel in every single volume throughout the hamartoma in a data-driven manner, and ask ourselves, where is this voxel within the hamartoma connected to the rest of the brain? And so what we saw is, like, for example, what you see here in this voxel location, here is how that voxel was connected to the rest of the brain, which I declared as abnormal because it shouldn't be connected if they don't have epilepsy. And so each voxel could be categorized in its degree of connectivity to the rest of the brain, and that can help show us where in the hamartoma we should aim the laser. And you might say to yourself, like, who cares? Just disconnect it. And then you'll know they're seizure free. And you would be right, only you would ruin their life forever, because this hamartoma, where it is attached to the rest of the brain, is right at the mammillary bodies, which you might recall are absolutely critical for learning and memory retention. And it's also connected to the hypothalamus itself, which is required to be alive. So if you destroy part of the hypothalamus or the mammillary bodies, you may render the patient completely disabled or dead. And that is, in fact, what was happening with other modalities of surgery that indiscriminately disconnected the hamartoma at the point of cleavage to the rest of the brain. And so we needed, for safety's sake, to devise a method to aim away from those structures if we could, yet save their life from the debilitating drug-resistant epilepsy. And that's essentially what we devised here, was a tool that I called Searchlight, where we could improve the lives of the patients with this epilepsy without endangering them. And we reduced the morbidity to 0 doing this, from a standard rate of about 20% of permanent significant morbidity after seizure, and improved the seizure outcomes by 45%. And here's a picture of us planning the laser trajectory in a more safe manner to the region within the hamartoma causing the seizures. So this was the first time in humans that we showed sub-centimeter seizure onset zones using resting state and improving patient lives. And we also studied these patients post-operatively, pre to post-op, to see if that also correlated with their seizure improvement, and in fact it did. And we compared that to other causes of epilepsy as well. Okay, we still have time. One more tool. So, one of the harder things within epilepsy is, once we come up with all the seizure onset zone candidates, which one is the right one? So even resting state can come up with more than one seizure onset zone candidate, and actually more than one could be correct. It is entirely possible that patients have more than one seizure onset zone. However, sometimes it's confusing if a propagation zone could be the onset zone, especially if the seizure onset zone is relatively large and would be debilitating if we destroyed the whole thing. Could part of that actually be just propagation zone? And so what we wanted to know is if we could harness the information from resting state to help us differentiate between surgical candidate, these seizure onset zone candidate regions. And so what our theory is that the epileptogenic zone should send excitation to propagation zones, and the propagation zones ideally should send inhibition back to the epileptogenic zone. And this is not a new theory. this is probably mainstream at this point, but we theorized that we could use cross-spectral dynamic causal modeling to essentially declare an assumption that this would hold true in our data. And so we applied the cross-spectral dynamic causal modeling to the simplest network possible, 2 nodes. So we know in our hypothalamic hamartoma population that for sure, the seizure onset zone was definitely coming from the hamartoma, because when we destroyed it, they became seizure-free. So that's as good as we can possibly know, because it was a lesion study. So if we go back to the preoperative data and we can say, okay, we know this was where the seizures were coming from, and we can see by the resting state where it went to next. And if we take those 2 nodes and we just kind of declare them blindly to feed them to the dynamic causal modeling, would the excitation come from the HH, and would the inhibition come from the downstream propagation zone? And in fact, that's what we saw basically every time. So we could use the direction of the signal to declare which one was the seizure onset zone, and this be a validation study in the most simple way to help us understand if our tool would work in more complex situations, which is essentially epilepsy from anywhere else. Okay, so we started applying that pre and post-operatively to also understand, similarly to all of our other validation studies, does it get better after surgery according to how much the patient improved? And in fact, that was the case. And we had relatively good accuracy and specificity, sensitivity. And what we also devised is this so-called Boerwinkle neuroplasticity index, that if the excitation and inhibition relaxed equivalently to 70%, then that patient would most likely become seizure-free. And in fact, they did. And the other unexpected finding is that the more inhibition that we saw from the propagation zone to the onset zone, the more likely it also was that the patient would become seizure-free. And this kind of makes sense if you think about it, because that seizure onset zone is poisoning the rest of the brain with its abnormal activity. And the longer that poisoning is going on, the more likely it is that the patient will actually develop independent regions of seizure onset outside of the original location. So essentially that epileptic activity is poisoning other locations. And as it poisons those locations, less inhibition is coming from them, less healthy inhibition toward the original bad guy, if you will. And so if we catch this early in this patient's particular journey of epilepsy poisoning, then we see more inhibition from the propagation zone, and we can predict their ability to heal with good neuroplasticity after the surgery and have good seizure control afterwards. So in summary, I showed you 3 tools and that we're using clinically right now in adult and pediatric epilepsy to help us improve surgical outcomes for those with drug-resistant epilepsy. And so I'll just kind of pause there and see what questions you guys might have for me.
Yeah, thank you. Thank you so much for the wonderful talk, Verena. This is really exciting, and I personally learned a lot. I know we spoke about your research before, but it's really nice to hear from you directly with slides. Any comments or questions to Verena?
This is Stephanie. I have a question.
Yeah.
It sounds like you've really been a pioneer in this area, and I'm just curious, just based on your observation of how the field has changed, the clinical field has changed over the last 10 years. How many centers are actually implementing this at this point? And like, what's your vision of how this is influencing or will continue to become sort of standard of care? What's sort of curious how that's rolling
great
out.
Question. Sort of the state of the union question, if you will. Clinically, I think we're the only one applying it because I'm the first one to learn how to bill for it and pioneer the operationalization of it, and have good reimbursement rates from insurance companies, which I started doing in 2012. And essentially, like, I've taught other other centers that have been using this from a research standpoint, how to bill for it, and they're just starting to begin to do that. So for example, St. Louis has been using this technology to map where the normal networks are around their lesions, but I don't think that they've been billing for it throughout this time, even though most of it was being implemented clinically for the patient's sake. So it's not obvious to doctors how to start new billing processes. And I certainly learned a lot by pioneering that and, meeting with the AMA and all the insurance companies and developing and working with the doctors so that it's practical and feasible and they don't get bogged down by saying, hey, we need to do this new test. And so we have a packet that goes out to the insurance companies of information. And a lot of times, really, the insurance companies are the ones that love this because they're the ones paying tens of thousands of dollars every year for the patient's drugs. And so if we can reduce the number of drugs or even go to zero, that's a huge cost savings for those payers. So epilepsy surgery is cheap in comparison to a lifelong of debilitation and drug costs. So with that in mind, we are the first national interpretation service for epilepsy surgery evaluation. So locally done resting states can be sent to us, and I can render a clinical interpretation, all of which is covered by the payers. So all the centers stay in the black, if you will, because they charge their own technical fees for the acquisition of the data, and then I perform the interpretation.
Hi, this is Viton. As a question about technical causal modeling. So could you share more how you choose the dynamic causal modeling? Because for the rational connectivity or effective connectivity, there are several tools or modeling, actually a lot of modeling about for the causality. For example, the structural equation model or granular causality. So how do you manage to pick this up?
So first, let me say the full explanation is in our paper in a step-by-step and explaining our theory. But essentially, we use cross-spectral dynamic causal modeling with a PEB analysis. So if I might, I'll go back one slide here. Essentially, we're showing the fixed effects between the two locations here in the simple network model, the two nodes. And so we have a probability that we declared at 90%. If the connectivity probability is over that, then we declared it clinically relevant. And so excitation was declared as positive values and inhibition declared as negative values of these in this model. And so, for example, in this particular patient, the seizure onset zone was inhibiting towards itself, but sending excitation to the propagation zone. And so patient by patient, each patient received their own individual analysis. We didn't do this in a group-wise basis because each patient would have their own normative data that we used. And so at the end, then we did a statistical analysis on the direction of the signal to declare the conclusions that you see here. So we did think about Granger and other modalities, but ultimately, after much discussion amongst the lab and our collaborators, we settled on this model. Now, I certainly don't claim that this model is superior to others. We didn't compare it to others. Actually, that's part of what Goshi Lee is working on right now, is seeing if there's a superior model already out there to this. However, given the degree of, I would say, relatively stable solution in this validation cohort, we have gone ahead because we don't have another model better at this point in time to operationalizing it for clinical use. Ultimately, what this affects is what locations we're putting depth electrodes into the brain from the resting state information. So we're not excluding other information, such as say from video EEG or PET or SPECT or, this types of modalities that also help us localize brain. So even though it's relatively new and we have these 2 levels of validation, the pre and post-op in this simplest example, we went ahead with it. The publication is in neuroimage from this neuroclinical image, I should say, from this year. Thank you for that question.
Yeah, by the way, is the SPN is the tool in the you can find SPN.
Sorry, there's some background noise with your question. I'm having trouble deciding.
So the dynamic causal modeling is the tool that you can find in the SPM.
Yes, you can find as dynamic causal modeling in SPM. That's true.
Okay, thank you.
Wonderful talk. I have a question. Like, so in practice, I know that deep brain stimulation can be also be used to treat the epilepsy. So how, in practice, how you choose whether to use surgery or deep brain stimulation?
Great question. So neuromodulation is not new, of course. There's vagal nerve stimulator, deep brain stimulation, recurrent nerve stimulator. So these are all neuromodulating based therapies for the brain. And so these are non-destructive as compared to the destructive approaches such as laser ablation or open craniectomy and removing part of the brain. So oftentimes what ends up helping doctors decide whether to use these neuromodulatory approaches versus the destructive approaches is if we think the patient has the seizure onset zone in eloquent cortex, such as, Broca's area or the motor strip, then we might take a neuromodulatory approach because of how much debilitation the patient would have postoperatively. Another reason to use the neuromodulator approaches over the destructive approaches is if the patient has generalized or multifocal epilepsy. So too many locations for us to be able to realistically destroy all those locations, then we would take a neuromodulatory approach. The downside to neuromodulation is that it's never curative. And the patient requires this machine in their brain, which puts them at risk for infection, requires battery changes, and generally takes months to years to show significant improvement, whereas the destructive approaches can start to show improvement, usually certainly by 3 months in, but sometimes quite a bit sooner than that, even day 1 after, and is the only curative approach is the destructive approach. So there are patients rarely who do become seizure-free on the neuromodulatories. They're just more the exception than the rule, unfortunately.
Okay, I see. Yeah, thank you.
Hi, Verena. I'm Song-ho, and I have a question regarding your surgical plan decision to use a fMRI, resting state fMRI as a golden marker. So in case, like at the first time, you identify that the anatomical and other findings is opposite with the functional MRI, how did you decided you're gonna choose the functional MRI marker as a surgical site? I'm just confusing because if I'm the clinician, I might be struggle what to use it. I might go to the other general marker have been using. So is there any the critical key that you considering as a decision making?
So certainly by the time we put the first depth electrode in a patient to help us understand if there was a seizure onset zone by resting state, we had long been using it for just understanding where the normal networks are. And we had been observing these types of findings in many patients. And then retrospectively looking at them and saying, you know what, that's where the seizure onset zone turned out to be by all the other modalities. So when there was concordant data by the prior modalities, then we started to notice this. And so by the time we got to that first patient that I showed at the beginning of this presentation, we had a pretty good idea that it wasn't, that it was probably seizure related. It just was the first time that it actually helped us direct where to put the depth electrodes. And certainly in that case, even you could see that it was concordant, at least with the side of the brain that the other modalities were pointing towards. So at least it wasn't discordant. Now that last case that I showed you, where it was discordant, even with this hemisphere of the brain, we had already published several validation studies before we felt confident about putting a depth electrode in a location that was discordant with all other modalities. So we had a relative degree of experience and validation by that point. And also finding that we were improving the patient's seizure outcomes using the technology. So we felt in these patients that it is worth the risk-benefit ratio of proceeding ahead with helping us direct usually the SEG, but sometimes there were cases, even in 12% of cases, SEG does not have enough ictal activity to help us understand where the seizures are coming from. And then we're left with using only the non-invasive data to decide if we should proceed with surgery or not. And in those cases, resting state can help also influence, regardless of the SEG, where, if we should proceed with surgery and where. Now, remember, epilepsy is a life-threatening condition. And so if we do nothing, the rate of death from the seizures alone over the lifetime is not insignificant. Patients have respiratory arrest, a lot of times in their sleep, and it's unpredictable who it's going to happen to, which year. And certainly all of the medications they're on cause significant morbidity. They're fatigued, they have brain fog, other complications related to the medications and the treatments. And so even the other treatments that are seemingly not destructive, if you will, are causing significant morbidity every day for those folks. So we don't take this lightly in trying to decide whether to proceed with surgery or not for these patients. And certainly it's a team approach. It's not myself deciding, it's everyone in that room, if you will, which usually there's several experts, including a neurosurgeon, several epileptologists, neuropsychologists, and so forth, taking care of that patient. And then ultimately the patient's family and the patient themselves deciding that it's worth the risk-benefit ratio for them.
Thank you.
And I do also have one question. So Marina, you show that you show a few power spectra, and they seem to look different, right, from the areas of interest. And is there any definitive threshold that you could use? Like, I mean, the power spectra itself has direct diagnostic value, and also if the answer is yes, then how important it is to scan faster. How important it is if we could push temporal resolution. For your operation, I guess.
Temporal resolution is huge. I mean, certainly the criteria that I'm using right now is generally past 6 hertz per 100 is the power spectrum. Past that, if it contains a significant amount of the power spectrum is above that, it's certainly more suspicious for a seizure onset zone. And keep in mind, though, we're using both spatial criteria and temporal, the time-based criteria. So it's both. And I wouldn't decide in isolation without one or the other. And also on top of that, the more independent signals that are spatially overlapping in one area, the more confident I feel that that's a higher likelihood seizure onset zone. And then essentially we just end up stack ranking the locations as this was the most abnormal and the next and the next. And we give that to the surgical team to help decide what to do. But I've been using the exact same sequence since 2010. And of course, the good thing about that is that I can say exactly what it should look like with this sequence, and any change to the sequence I have to revalidate, if you will. However, 20 minutes of scan time is not trivial. And if we could actually get better results with even shorter scan times, we are very interested in. For example, right now we're trying to validate a multi-band sequence, and we're just kind of in the first steps of that. And it's tough going with a clinical scanner to do this kind of validation on drug-resistant epilepsy patients. And so it takes a lot of patients to make headway in this space. So I'm certainly open to help from all the wonderful collaborators over there to jumpstart that process.
All right, thank you so much, Verena. I think we're already on the top of the hours. And if any of you have additional questions to Verena about the talk, about opportunity to collaborate in the future, I'm pretty sure that you can, Google her emails and okay, it's right here. You can find it pretty easily here. So thank you again, and thanks everyone. Enjoy the Thanksgiving break.
Yeah, thanks for the opportunity. Appreciate all of you guys coming out. Take care.
Yeah, thanks. Bye.
Thank you.
Thank you.